Assalamu alaikum. Again, it happened with me before. I was between the audience and the lunch. So it is happening again. Bear with me. I'll try to, move faster. My talk is not that comprehensive. I tried to be focused to the biologics only during pregnancy, and it is the topic of the day, because we know. So when I start, there is no disclosure, and I will talk a little about physiology of placental transfer of biologics. Beta thoda side pe ho jana, I forgot to bring my glasses up. And biologic drug-induced maternal and infant immunological changes and evidences and recommendation. So when we talk about systemic autoimmune rheumatic diseases, thank you so much. We know that it's the disease of women, especially the women of childbearing age. So it's normal, and it's our daily routine that we see the patients who are pregnant or planning pregnancy, and they've got diseases that are uncontrolled or not completely controlled. So we know that systemic autoimmune diseases, they can flare the pregnancy, and they can negatively have an impact on the disease activity of the pregnancy and can alter the outcome of pregnancy at the same time. Therefore, it is crucial to have the disease controlled throughout pregnancy and even before the conception as well. At the same time, we face problem with the conventional DMARDs. Many a times, we are unable to control the disease activity with just conventional DMARDs, so biologics are imperative. So most of the biologics which we are using currently in the autoimmune conditions are immunoglobulins. They are either fully monoclonal antibodies or antibody fragments. IgG1 is the most experimented and clinically used IgG subclass in biologic development, and the switch from chimeric to fully human antibody has improved the safety and tolerability of the mAbs. When we talk about the transport of immunoglobulins across maternal barrier to fetus, IgG and low levels of IgA are the only antibodies that get transferred from mother to the fetus. In early pregnancy, there is insignificant transfer through passive transfusion, passive diffusion, but later on there is a process through which they get transferred, and the level of immunoglobulin increase steadily in the blood of the fetus. It is supported by different type of receptors called FC receptors and FC placental receptor, which is gamma. It promotes, I will tell you on the So these are the mAbs or immunoglobulins. They get attached to the FC receptors in the endocytes of the placental syncytiotrophoblastic layers, and these endosomes, they then transfer this complex across the layer and then into the fetal circulation. So here we can see that even if the biologic levels stay stagnant or normal in the maternal blood, they continue to rise by the end of second trimester, and then they reach to their peak at the time of the birth. So we know that the antibody formulations, by this cartoon, we could see that the antibody formulation lacking FC portion, like certolizumab, are less readily transferable IgG classes. Therefore, they are considered relatively safer during the pregnancy. Now we know at the same time that pregnancy itself is a complex immunological condition. There are changes in the human body. At the same time, these systemic autoimmune rheumatic diseases, and if the patient is using biologic therapy, the changes are further complex, and it is considered as an immunocompromised state leading to the susceptibility of various infection. So administration of biologic drugs causes an increased burden on the body and the immune system. But at the same time, there is insufficient data which covers this level in the women But there is sufficient data in infants, especially about infliximab and adalimumab. They have checked the cord blood level of these drugs, and they found that infliximab was higher in the cord as compared to adalimumab. The reason we have already learned, while the level of the certolizumab, etanercept, and eculizumab were negligible. Most drugs with high levels at birth persisted for a couple of months, but then they subsided or vanished from the fetal or neonatal blood by themselves. There was also harmless, reversible, low infant total and B-cell lymphocyte count was identified, which was considered to have a negative impact on the vaccination course after rituximab and belimumab. This was a very good paper, which was published in 2017. It showed the effects of pregnancy on pharmacokinetics, kinetics. Now, interestingly, when I looked into the papers which were published about the biologic safety and efficacy during pregnancy, most of the papers were published by gastroenterologists related to inflammatory bowel disease, because we know that TNF inhibitors are very much in their use as well. So when they measured infliximab and adalimumab blood levels in 25 patients of IBD, they found that there was increased level of infliximab in the blood during pregnancy, and it was an unexpected finding. They had to stop infliximab due to increased risk of infections. Another paper Assalamu alaikum. Assalamu alaikum, Pakistan. I'm sorry, but I expect, and the people who have traveled from other part of the Pakistan, at least they expect that you respect their presence and their efforts. Thank you so much. So this is the paper which was published in 2014. It was again anti-TNF impact if administered in pregnant women with IBD. 25 children were exposed, and 80% were also breastfed. 7 children only had mild decrease in immunoglobulin level, IgA and IgG, without any clinical signs. There was a relatively higher risk of upper respiratory tract infection, but it happened long after the clearance of those antibodies of the drug. Another paper, it was a good large paper from a French cohort, Evasion, which considered 1,500 anti-TNF exposed pregnancies as compared to 10,000 non-exposed patients. Maternal infection rate was much higher in the exposed patient as compared to non-exposed people. When we talk about tocilizumab, this analysis, it was published by Roche, post-marketing analysis. They divided the group into 2, retrospective and prospective pregnancies. 180 prospective pregnancies, they resulted in about 60% live births, 21% spontaneous abortions, and there were malformation as well, 4.5%. So it was pretty dangerous data actually. And the retrospective data was much worse than that. 50% had live birth, which is much lower, and 28% had spontaneous abortion, and fetal malformation was in 3 infants. While the fathers who were exposed to tocilizumab before pregnancy, the fetal outcome was normal. Again, rituximab, they showed a systematic review and case series in which 78 resulted in live birth and 12 spontaneous abortions if the pregnancy was exposed within 6 months of conception. B-cell count was lower in 39% of the newborn and normalized within 6 months. Case series of 11 patients showed uneventful pregnancies. So this was the hard part actually to listen to. When we come to evidence and recommendation, a very encouraging data in which about 5,000 women with childbearing age of rheumatic diseases and IBD, who were exposed, out of which 1,000 patients who were exposed to biologic at some stage of their pregnancy, they had comparable live birth in both the groups, but the patients who were exposed to biologics, they had higher rates of IUGR, preterm delivery, preeclampsia, and C-sections. Another data which showed that comparable pregnancy outcomes in patients who had disease matched control and chronic inflammatory disease-free pregnancy through GRADE approach. So these two studies were a little encouraging as compared to before. We know that we have to talk to our patient about preconception counseling every time they visit us, even if they tell us they are not planning pregnancy, but every time, or many a times, at least it happened to me. Today I counseled them, started with a teratogenic therapy, and in the very next visit, they gave me the khushkhabri of pregnancy. So, I mean, I don't know who's to blame here, but we have to, keep telling them that it's not going to happen. You should be avoiding this, but yes. So we know that if the disease is under control at the time of conception, the outcome of pregnancy and the patient's disease and patient life would be favorable. I'm just going to briefly talk about the British Society of Rheumatology guideline, because they are the latest one, published in 2023. They said almost the same thing for most of the drugs. TNF inhibitors can be continued throughout pregnancy, especially if the disease is not under control. But if it is in remission, you can consider stopping infliximab at 20 weeks, because we learned that the blood level in the cord was higher as compared to other TNF inhibitors. Adalimumab and golimumab should be stopped at 28 weeks. Etanercept can be continued till 32 weeks. Neonatal vaccination, if the patient is exposed throughout the pregnancy, then avoid live vaccine till 6 months of the age after delivery, and vaccinate on schedule with non-live vaccine or rotavirus. They are compatible with breast milk exposure. For rituximab, there is limited data available which showed that they are teratogenic, but again, there is insufficient data that can make us confident that it is compatible with the pregnancy. It should be stopped before pregnancy, before conception, but in case you do not have any other option available to control the disease, yes, the patient's life is more important than the pregnancy. If the patient is, if the fetus was exposed to rituximab in 3rd trimester, then no live vaccine till the 6th month of age, and she can breastfeed the child. For tocilizumab, there is limited data which shows that it is teratogenic. At the same time, insufficient data to make us confident. And again, it can be considered if there is no other safer option available during pregnancy. However, we know that during pregnancy, its exposure will be harmful to the fetus. When to stop? Consider stopping before conception. Again, if used throughout the pregnancy, you have to delay the vaccination till the age of 6 months. This goes with all the coming drugs now for IL inhibitors, anakinra, canakinumab, belimumab, secukinumab, ixekizumab. All of these, they do not have sufficient evidence that they are teratogenic, but at the same time, they do not have sufficient data that they are safe during pregnancy. So in special circumstances, we can use them to save the patient's life. For tofacitinib, because it's a newly launched drug, again, we have insufficient data to make any recommendation during pregnancy. They should be stopped at least 2 weeks before planned conception, and there is insufficient data to JAK inhibitor in breastfeeding, and given that they are likely to be transferred in breast milk, so they should be avoided during breastfeeding. Now the key points are the same. With regard to biologic therapy used during pregnancy, individual drug effectiveness and transplacental transfer should be taken in consideration. All anti-TNF inhibitors are safe during pregnancy. Other drugs, they might be effective for treatment, but they should be avoided. Very limited data is available for tocilizumab and other MABs, and non-live vaccine should be avoided in patients 6 months after the birth if the pregnancy was exposed to these biologic during pregnancy. Minimal transfer in breast milk is found for various drugs, but again, TNF inhibitor biologic DMARDs are safer than non-TNF inhibitor biologic DMARDs. Treatment with the following drugs is considered, has not demonstrated any clinical relevant impact on fertility or pregnancy outcome and can be continued in male patient trying to conceive. This applies to all the drugs you have, these are listed here from methotrexate till mycophenolate, but you have to consider the pros and cons. Thank you.